Thank you so much, Keo. And I just want to dispel things before I start. I did not develop Starling's law of the heart, in case you wonder. I get asked that question almost once a day. So when I was very honored and flattered when Keo asked me to give a keynote address to this esteemed group, and I thought about it, and I decided I'm going to basically tell a story, which is what I have witnessed during my career and things that have influenced me. And I was kind of in the midst of seeing this field develop. There were no advanced heart failure cardiologists when I was completing my fellowship. There was no heart failure fellowship at the time. So these are my disclosures, none of which are relevant. So what I'm going to go through is going back to when I was a medical student, and as of a month ago, I'm Professor Emeritus. And I think one of the key learning points, and there's a blend between entertainment and education. So I hope that we accomplish a little bit of both. But we are all shaped by mentors and luminaries. And you have these by chance interactions with people that you don't realize until many years later what the impact of that was. Let's begin. So 1980, I'm a medical student in Philadelphia. I have no idea who this person is, and I'm invited to a dinner, which is an Alpha Omega Alpha ceremony dinner reception. And in walks this gentleman with a suitcase, who had worked at the Cleveland Clinic, ironically. That's where I wound up. And it was Wilhelm Kolff. And he opened the suitcase and started passing around pieces which were the total artificial heart. And interestingly, as you heard this morning, he was the first president of this society and worked at the Cleveland Clinic from 1950 to 1967. And reading the history is very interesting because, and he's not the first, he basically was not held in good light at the administration. So it sounds like he essentially got pushed out and made his way to Utah. So now I'm a senior medical student, and it's my last rotation working in the intensive care unit. And my patient has a cardiac arrest. In comes running this very tall person while I'm doing chest compressions, who takes a very long needle and injects intracardiac epi into the heart. And after a minute or so, he said, "This patient's dead, and I'm going to take him across the hall and put a total artificial heart in his chest." I had no idea what was going on, but live and learn. So I saw this happen. So I completed medical school. I went to Pittsburgh. That was very impactful, working with Bartley Griffith and the whole team there and seeing heart transplantation come to life, learning a lot about Thomas Starzl, who was another luminary who made quite an impact on me. But my chief of cardiology was Carl Lear. And what did Carl Lear do? He basically brought dobutamine into the clinical world. And he was somebody that instilled in me, keep your eyes open, ask questions, don't be afraid, take risk. So My journey at Ohio State ended when Eric Topol called me and gave me the opportunity to go to the Cleveland Clinic. But before I left Ohio State, I had the chance to work with Dr. Timothy Galbraith, who's no longer with us, but he arrived. We did our first heart transplant there in 1986, and we had Thoratec bivads. So I got to see those in action. And as I was finishing up my cardiology fellowship, a 30-year-old comes in with fulminant myocarditis, which when that patient hit the ER, Dr. Galbraith said, "Send her to the OR, I'm putting her on bivads." I came in the operating room, we did an endomyocardial biopsy. The patient had fulminant myocarditis. We had this mindset that maybe she'd recover. So she wound up being supported 23 days. We did another endomyocardial biopsy. It showed that there was just extensive fibrosis, ongoing inflammation, and being an impetuous cardiology fellow, we submitted this case report to the New England Journal, which it promptly was rejected and wound up, courtesy of Bill Roberts, in the American Journal of Cardiology. But we made a statement then that this experience suggested histologic evidence of myocarditis plus no improvement in ventricular function are indications for proceeding to transplant. But we were thinking about supporting this patient with hopes that she might recover. So the other person that dropped in before I left Ohio State was this gentleman on the left whose name has been mentioned multiple times so far today, Robert Jarvik. And why did he come? Because Kevin Murray, who had just come to Ohio State after leaving Utah, brought us the total artificial heart. So I got to do some animal work with calves with TAHs and develop some experience in humans. So that was quite an impactful experience. But as I mentioned, Eric Topol made the offer to me in 1995 to come to the Cleveland Clinic. So I get there, and Patrick McCarthy is somebody that definitely had a major impact on how my career progressed. Pat was one of these guys that had no fear and always wanted to push the envelope. And Jim Young, who had trained with DeBakey and Dr. Frazier, who I saw here this morning, kind of had that same mindset. So shortly after I got to the Cleveland Clinic, Pat said to me, "We're going on a plane and we're going to Brazil." And talk about doing crazy things. I wasn't, but my surgical colleagues were cutting chunks of people's hearts out, doing the so-called Batista procedure or partial left ventriculectomy. So this was one of the first things that I was involved in where we kind of scientifically were able to demonstrate that this really was not such a good idea. But that experience then went from partial ventriculectomy to these two gentlemen that I had the privilege to spend some time with in a desolate, ugly place called Monte Carlo in Monaco. And Vincent Dorr was another individual that would look you in the eye and say, and you heard it this morning, the word no doesn't exist. It's maybe. And you just have to have an idea and pursue it. And one of the things that really floored me, I'm in Monte Carlo at this symposium, and Sir Magdi Yaqub is called up to chair a session, and he gets on the stage, he's on the podium like this, and he says, I see Dr. Starling out in the audience. I want him to come up to the stage and co-chair this session with me. So that's the type of magnanimous individual that this person was. So these two surgeons really taught me a lot. And then when you get into disruptive innovators, which you've heard that term before, so the CEO at the Cleveland Clinic when I arrived was Fred Loop, who I had the privilege to have an interview with. And Dr. Loop calls me up one night and he said, I want you to come to dinner. So I go to the dinner and I meet Jerry Buckberg. So every cardiac surgeon in this room, I'm sure, uses the Buckberg solution. So at this point in time, Jerry was no longer doing cardiac surgery, but he was obsessed with the surgical ventricular restoration. He started kind of a counter-current group of individuals, and he essentially, and this is not slighting the NIH in any way, but the NIH took a different tact with the Stitch trial, and the rest of that is history as to what the pitfalls may have been with the Stitch trial. But Dr. Buckberg kind of embraced me and supported me, and I had a number of publications with him. So every time you get an opportunity with people like this as you're moving along, it's priceless. So here we are in 1998, and some of you may not know what this is. So this is a retired orthopedic surgeon. I get a phone call from a cardiologist at a well-known institution in Boston, and he said, we have a gentleman, he's too old, he has pulmonary hypertension, renal failure, would your center be willing to take a look at him? So he comes to Cleveland, he gets a balloon pump, Pat McCarthy walks in, he spends about 5 minutes, he said, take a day or two, then I'm gonna put a heart-made XVE in this man, and we'll see what happens, and maybe we can transplant him. And what happened is his renal failure reversed, his pulmonary hypertension was reversible. The term bridge to decision did not exist at that time, but this is somebody that wasn't a transplant candidate, but courtesy of mechanical circulatory support became a very viable transplant candidate, transplanted at age 73, who lived into his 90s before he expired with his transplant. So we were one of the first, not the only, but we were one of probably 10 or 12 centers that were putting the heart-made XVE in. So before rematch, there was pre-match. Pre-match was kind of the safety study. So when rematch came along, my surgical colleague, Dr. McCarthy, said, it's unethical. How can I randomize a patient to medical therapy versus a heart-made XVE when I know what the heart-made XVE will do? So it turned out we didn't do much as far as randomizing patients in rematch. But at that same time, I got to meet this gentleman, also a past president of ASAIO, Pierre Portner. Just another giant who would come up to you like he'd known you for 20 years. You were on the same level as him, but he was a genius as far as mechanical circulatory support. Unfortunately, the NovaCore device did not have a long history. I happened to be on the DSMB for the Intrepid study, and the NovaCore kind of quickly disappeared. So fortunately, courtesy of the luminaries that were introduced this morning, the Lifetime Achievement Award winners, more pumps came along. So we get the HeartMate 2, we have a continuous flow pump, and lo and behold, we see that there's incremental improvement. It's way better than medical therapy. And as I mentioned in a lecture yesterday, we thought this was the be-all, end-all. We had reached the panacea of mechanical support, and we needed to take off and run with it. And I wrote this editorial in 2010, Improve Quantity and Quality of Life, a winning combination to treat advanced heart failure. Turns out I wasn't right about that decision, but as all this was happening, the media really jumped all over this, and I get contacted by a reporter, Ron Winslow, from the Wall Street Journal. This photograph was a patient at Duke that appeared in the article. I was quoted as saying, "We're seeing a transition in care for heart failure." I thought that was true, but it turned out there were too many issues with the HeartMate 2. And then when Mr. Cheney became a recipient of an LVAD, which he visited the Cleveland Clinic and told us that he was going to live on an LVAD forever. He changed his mind. I think he's living today with a transplant, but this was MSNBC was all over this. So this article has many citations. So I want to tell you briefly the background on this article. So David Farrar, who was a good friend and colleague, he approaches me and says, "Okay, we've got the New England Journal papers. Why don't we look at what the outcomes are in the Intermax registry?" So he provided me with that data. I submitted it as an abstract to the Heart Failure Society of America. They accepted it. It was a poster presentation at the Heart Failure Society. I then wrote a manuscript, sent it to Jack, and I think it's the only publication that I got a letter back, paper accepted, no revisions, and this paper gets, I see it quoted a lot because it was one of the first that showed when you move from a clinical trial into widespread dissemination that the results were very, very good. So, as this was all happening, everybody, courtesy of Lynn Stevenson and many others, and this is a paper we published in Circulation Heart Failure, we knew that survival with inotropic therapy was bad. And so now we had an LVAD that seemed to work. It wasn't perfect, but we were asked by the editors when we wrote this paper to add this sentence: if a patient is not a candidate for LVAD or transplant, they should be referred to hospice. So the point being, inotropic therapy is really not in the mix. So a little bit I want to tell you about the Revive It trial. So the Revive It trial, and I see Dr. Watson in the audience, so Tim Baldwin and NIH, they put together a working group. And basically the concept was we should look into implanting patients that aren't on inotropes. We should move into an earlier population. So this is 2009. So the NIH puts an RFA out. I hook up with my friend Joe Rogers. He's at Duke at the time. And we form a consortium. We submitted to the NIH, a Cleveland Clinic DCRI grant to do this. We have other collaborators involved. And unfortunately, we had some of our collaborators that were also collaborating with other groups that were submitting. We didn't know that, but the NHLBI awarded this to the University of Michigan Consortium, which was Michigan and University of Pittsburgh. So we did not receive the grant. We were disappointed. Thoratec, HeartMate 2, said, we're going to do a trial anyway. The Michigan group, their proposal was with hardware and the HVAD. So David Farrar and Jack O'Connell, who was the medical director or the CMO with Thoratec at the time, we put together a study. It was non-randomized. It was 100 patients. It said, I don't want an LVAD, just treat me. The other 100 said, let's go with the LVAD. We showed that survival was the same, but we showed a lot of the patients did wind up needing an LVAD. So it's a high-risk patient population. So there we are with the HeartMate 2, the HVADs on the scene. And here's another group of people that have worked with me a lot and made big impressions. So Bruce Lytle, who was my boss for a long time, he calls me to his office and said, I'm hearing there's a lot of bickering going on. Dr. Smadera is telling me the HeartMate 2 has got some issues. Dr. Mazami is telling me it doesn't have any issues. And Dr. Lytle said to me, I want you to talk to Dr. Blackstone. He's the statistician. I want you to analyze the data. I want an answer in 3 weeks. So we went to work, and we get the data. We had a conference call with the CEO of Thoratec. We didn't know at the time that the FDA was also aware of some things that we just didn't know. We only knew what we had seen internally. We submitted it to the New England Journal, and the New England Journal said, we are not going to publish this. It's from one center. It has widespread implications, and you're going to need to get data from other centers or from a registry before we'll even consider it. So fortunately, my colleagues at Duke, Dr. Mazami, who had been at Washington University, we got together and we got additional data from other centers. Everything was aligned. So this gets published in the New England Journal. And there are individuals in this room who wrote letters to the editors challenging our observations. That's fine. That's what academics is all about. But ultimately, when a head-to-head study was done, it was clearly shown that the HeartMate 2 had an issue with pump thrombosis, which the HeartMate 3, fortunately, does not. This got media attention. And the irony of all this, so the award was granted in January of 2011. The FDA failed to approve the initial IDE for the HVAD. They had safety concerns. In May of 2012, FDA was asked to reconsider. They still said no. September of 2012, Heartware and the Revive It group at Michigan and Pittsburgh, they separated. And ironically, they had to turn around and go back to Thoratec and the HeartMate 2. They got IDE approval. And in mid-2013, concerns for the pump thrombosis in the HeartMate 2, in addition to what we published, and the trial was terminated. So that's Kevin Baroque, who came and talked to us at the Cleveland Clinic as the HeartMate 3 was coming on the line. So what about the HVAD? So before I show you that slide, fortunately, we have the HeartMate 3 today. The data is great as far as survival, but I had the good fortune to be involved in this work. Sungmin Cho, who was a neurology resident that I worked with at the Cleveland Clinic, he approached me and said, let's do a systematic study. So we submitted to Intermax, and here you see the data that was published in Circulation that showed clearly between the HeartMate 3 and the HVAD, there was more neurological events. Shortly after this paper was published, Medtronic made the decision to stop distribution of the HVAD, and it was related to these neuro events. So just a word or two about recovery. Is this reality or fantasy? So here I am with a young woman who had a HeartMate 2. Her heart completely recovered by every standard. We had discussions with Emma Burks and Stavros. So Dr. Smedera took the HeartMate 3 out. Patient did great. 3 weeks later, she crashed and was on ECMO and had another HeartMate 2 put in. So recovery is a very humbling story. Applause to the two individuals here that are continuing to generate data on recovery. And I think the future is still bright for recovery in certain circumstances. So the last phase of this talk, I just want to mention some of the future things, which is, we focus on the machine, the device. We know that there are human interfaces. So certain adverse events like GI bleeding are different in the Japanese population versus the US Caucasian population. And now we're beginning to focus on management. So Jason Katz presented this data, which is a post hoc analysis from ARIES and HeartMate 3. And the punchline here is the combination of specific medical therapy may have additional ramifications as far as the primary impact. So we're just beginning to scratch the surface in this specific domain. The area that I've been particularly interested in is PDE5 inhibition. We've published a number of papers on this topic, including in the Intermax registry. And I've gone to CTSN and the NHLBI. The problem is that the event rates require very, very large sample sizes in the range of, say, 2,000 patients. So there are challenges as far as funding is concerned with this type of research. So yesterday afternoon I had to duck out, but CTSN has made a decision to look at Abixaban versus warfarin in LVAD patients. This is now at the stage of a protocol development committee. We think it's going to have a sample size of about 600 patients, so stay tuned on that. I mentioned this yesterday, but this is the uplifting data that we have from near Uriel, and again, it's from Momentum, looking at patients under age 50, showing basically equivalent outcomes to heart transplantation. So you've already heard the buzz at this meeting about partitioning, and Dr. Frazier gets credit. 20 years ago, he was at a Cleveland Clinic symposium, and he said, don't transplant a 20-year-old, give them an LVAD, you're going to extend their life. And now we've kind of gone full circle with that discussion again. So there are many challenges with research in this field. There are funding limitations, there are recruitment issues, we need to standardize endpoints, there are global disparities, there are ethical and logistical challenges, but the beat goes on. We have to continue to push forward. I want to congratulate and thank my colleague, Dr. Fukamacha, for giving me this opportunity, and working with him and Dr. Karamov. over the years, and my current surgical colleagues, Dr. Soltesz and Dr. Tong. And with that, thank you for the opportunity to vent and tell you my journey. Thank you. Oh.
Thank you, Randy.
I have one last slide. We are in New Orleans. So let me tell you the story here. So this slide is from Gonzo Gonzalez, who's a cardiac surgeon. So the person in the middle, his name is Frenchie. He has an LVAD. Frenchie, I think Gonzo was here in New Orleans giving a lecture. He latched on to Gonzo. He came to Cleveland Clinic. I think he was the Grand Marshal of the Mardi Gras parade. So evolution is a process of change and improvement. We must all study, learn, believe, and communicate to advance the field. Thank you.